side and get it together. This morning's topic, they put it under geriatric conditions, but this morning's topic is pretty heavy. And the last time I presented this topic, everybody came in, good morning, everybody was excited, and by the time it was over. So I hope that we don't have that today, but it is a topic that we as pharmacists, we do have to be aware and have some type of knowledge about how we play, what role we play with our patients. Our whole profession, we thrive and we're excited to prescribe and recommend medications to keep everybody going. But we also have to talk about end of life and what that looks like and what your role is like. What does it look like for the patient? What does it look like for the family? How can we support the family as pharmacists? What's our role? What is hospice? What is palliative care? How do we get there? And so I'm just going to start off with a couple questions. Those are the objectives of today's lecture. We'll talk about hospice, palliative care. We'll go back over the Beers list. I know y'all remember the Beers list. We'll go back over that if we have time. If I come back next week as well. So, in your words, what is hospice? What is hospice? When somebody says hospice to you, or what does that mean to you?
Keeping them to the
end of life care.
It's like that transition to make the patient comfortable, until
they go.
Yeah, no more curable.
Huh?
I'm trying to say, at that point in time, the very person, we are not looking at curing the person, but just keeping them until he gets to.
Palliative treatment? That's hospice?
No.
It's part of it. It is part of it. It is part of all of your responses are correct. Hospice is what the patient basically has about 6 months, and the doctor has documented this in the medical chart. They have about 6 months to live. Estimated, some people can go on hospice and live for 2 years or so. So it doesn't mean we don't know. We're humans. We don't know the time or the day that. But from medical science, we know we have given the best care, or we've given all that we can do that we know. So now they may recommend hospice. What is hospice? These are different definitions for hospice. Again, it's anticipated life expectancy is 6 months or less when there's no cure. We've tried everything. We've exercised everything that we know, all the research, everything that we've done, all the different therapies we can come up with. There's nothing else that we can do. And so we shift the care from trying to cure the person to just trying to manage the symptoms of that disease state, of whatever it may be. That disease state could be cancer, it could be end-stage CHF, it could be end-stage COPD. You've had those topics already, right? You've had CHF,
Yes,
you've had COPD. Have you had some chemo, some oncology topics yet? Okay. So everybody don't always recover from some of these disease states, and so we may have to recommend hospice at some point. Hospice. Do you think hospice has anyone dealt with a hospice team? Personally? So on that hospice team, was it one person, 2 people? No? Who? A team of who?
So we had the internal medicine doctor, we had a cardiology doctor, pulmonary doctor, they all had to sign off on it.
Mm-hmm.
And then that's when we transitioned and went to the hospice care.
So what happened, what she's talking about is that apparently the patient was probably inpatient, and so the team inpatient had to come together, and everybody, the pulmonologist, the cardiologist, everybody had to basically agree that we have done what we could do, and now they are referring the patient to hospice care. So when we refer the patient to a hospice care team, now now it's a different doctor that picks up, and it's the hospice doctor who is the coordinator of the team, but that team is interdisciplinary. It includes pharmacists. You have a role there. Believe it or not, this is another career path, if you will. But you have pharmacists on the team. You have physical therapists, occupational therapists. You have nutritionists. You have nurses, of course. One might say, why do we need a physical therapist? Why do you think we might need a physical therapist?
You have to make sure, so that they don't form any clots or wounds.
Wound care. We use a lot of physical therapy in that setting. Wound care. Say your patient is bedridden and things of that, or maybe they have diabetic foot or whatever, and they come in and they help to do the wound care. They also may help, just because you're on hospice, that doesn't mean you're bedridden. And you can still get up and move around, but maybe the physical therapist can help them with transferring from the bed to the wheelchair, or from the bed to the commode. Physical therapy is very much needed. Maybe the patient had a massive stroke. Speech therapist comes in to help the patient communicate even at that stage. Because just because you're on hospice, that doesn't mean that you can't still talk, and sometimes patients are still able to talk and walk and communicate. We just can't cure what their medical condition is. So the entire team is just really centered around, what does the patient want? What does the family want? How do we make the patient most comfortable? And how do we also make the family most comfortable during this difficult time? What do we do? So you may have social work involved, psychotherapists involved, spiritual chaplains, non-denominational. They may be a part of the hospice care team. And also you may have religious, spiritual, we talked about one more. So mentally, it's a lot goes on mentally, as you can imagine, as the one has now been deemed not curable and has been told that perhaps 6 months or less, but there's nothing else we can do, but you still have all these symptoms of your condition. So you end-stage COPD, shortness of breath, fluid overload with CHF, extreme pain with certain cancer diagnoses and things of that nature. Alzheimer's disease. Why might a person end-stage Alzheimer's disease, why might they end up in hospice? Anybody can take a guess at it? What happens in Alzheimer's disease?
The memory is deteriorating.
They deteriorate.
The memory is
They
deteriorating.
forget.
Yeah.
They forget to do what?
Take their
Take care of
medication.
themselves.
So everything is just kind of breaking down. So the ability to chew, the ability to swallow, all of that, they lose that function. So it's not the disease itself that is the demise, it's actually the complications. So when you hear people say, oh, they died of Alzheimer's, well, it really wasn't the Alzheimer's, it was the complications from that disease state. So think about it, if you're not eating properly, what's your nutrition like?
Alone.
So they tend to be very frail. They haven't had, not able to eat, the chewing thing, the swallowing, aspiration pneumonia. Have y'all had that lecture yet? No? Infectious disease, aspiration pneumonia, y'all haven't heard of that one? So that group of people, because of the difficulty swallowing, then they can experience aspiration pneumonia, which could then also contribute to the ultimate demise. When they're not eating, and we have to introduce PEG tubes, G tubes, feeding tubes to the patient, when we So then it could be sepsis that ultimately is the diagnosis for the death of the patient. So it's not necessarily the disease state, but once that patient gets to the point in the Alzheimer's disease state where they're unable to do these things, then these are real conversations that the family and the doctor and the team is having, how the patient may get to hospice care. Any questions? Comments? So what does hospice do? Manage pain and symptoms. Any symptom that the patient may have that could be deemed as suffering, hospice care team manages that. It could be psychosocial, where we have the mental health therapists come in and talk to the family, talk to the patient, if the patient is able to communicate back and forth. One of the things I do want you to take away from the whole hospice thing, just because you go on hospice, it doesn't mean that you're not able to communicate your needs, your wants. Provides emotional, psychosocial, and spiritual aspects of dying, what's to come. People may want to have that conversation. The patient may want to have those conversations. Certain things may want to be highlighted during this time of reflection. The family may need some things, some tools to help them cope with watching their family member in this state. Hospice provides drugs, medical supplies, and equipment. Oftentimes when we, sounds like we had a patient that was inpatient and then they transitioned to home hospice. Well, in that transition, they had to get certain supplies such as a bed, a hospital bed, probably had to be transferred over to the patient's home. Because again, we want to make the patient comfortable. It's not there, but we want to make the patient comfortable as possible. So if we need that hospital bed to help them be comfortable, then that's transferred over. Any supplies for wound care, any supplies to help the patient and family member be more comfortable. For example, if we go home with hospice, if the patient goes home with hospice, the family is taught there's a medical box. And in that medical box is certain drugs in there to treat pain, agitation, and things of that, nausea. And the family is then taught to how to use what symptoms, when is it appropriate to give the pain medication. The family is taught when to do that. One cannot go home with hospice without 24-hour family support. Why do you think that's important? Family support. Why do we need family support during this time? Why do you think?
You can take care of yourself.
You can't take care of yourself. Even though you're able to walk and talk, anything could happen. And so you need, because remember, who's going to manage that box if you're in too much pain to get to the pain medicine? Who's going to manage that box if you can't get to the nausea medicine? Or you get so agitated, you might not even know you're agitated, but the family is really the eyes and ears for the hospice team. The hospice doctor wouldn't come to the home that often. They may have visits, weekly visits or so, or maybe every few days or so. The nurse wouldn't come every day, but the family is the contact, the voice, the eyes, the ears for the patient and the team. So it's not an option. It's not an option that we don't want to deal with the patient anymore at home, so we'll just put them in hospice. That's not how hospice works. It has to be a medical, the doctor has to have written in the chart the recommendation based on that patient's medical history and everything. Respite. Anybody heard of respite care? So oftentimes when, remember we talked about that the family has to be a part of this 24/7, it's not optional. Some families, what they do, they take shifts and they may stay with the family member in shifts, or maybe the hospice patient will go to one person's home. They'll work it out, but somebody has to be there all the time. Now if that one somebody does that person take care of themselves? What do they do? When do they get a break? So that's when they came up with the respite. Respite care is for the caregiver. So remember, hospice care is not just for the patient, it's also for the family. So respite care is an opportunity to give the caregiver a break. How does that work? Well, they have places where we can send the hospice patient to for a few days to give the caregiver some time to take care of themselves, go to doctor's appointments, go out of town, have holidays, and things of that nature. And so the patient would then maybe go to a facility, a hospice house, or they may have a caregiver, a hired caregiver come in, the respite services come in to allow the caregiver some time to do whatever it is that they need to do. Once you go on hospice care, sometimes we get it, people get it a little confusing. Once patient go home with hospice, is that the end? No, it's not. But it is the end of you taking the patient back and forward to the emergency room. Once we've signed and admitted the patient under hospice care, then remember the medical box that we talked about that's full of drugs there that the patient is taught how to use those drugs, and the doctor and the nurse, they come in every few days or so and check and make sure everything is okay, or status quo, I guess. But if the patient gets into a crisis, too short of breath, or gets into something where the family feels super uncomfortable with, it's not necessarily the time to take the patient to the emergency room. You take them back to the emergency room, they stop the hospice, and we start actively and aggressively caring for the patient again. So sometimes when people who have not been fully educated on what hospice does, and there's still some fear, we're not excited about it, so there's still some concerns, and so when we see our family member not doing as well, then they want to take the patient back to the hospital. You take them back to the hospital. That's your choice. But it starts the whole re-diagnosing and trying to take care of the patient for a condition that we already know that there's nothing else we can do. So when they go on hospice, they typically have a DNR, do not resuscitate. But if you bring them to the emergency room, what do? We provide care. So we will do the aggressive, we will resuscitate, and things of that nature. So the education piece about hospice, everybody goes through a lot of education. We don't just send patients home with hospice or families home with hospice without fully educating them on what potentially is to come. Even after the patient passes away, there's bereavement care for the family. The family is then supported with bereavement care, counseling for the death of their loved one. Friends and family can be a part of that. Every now and again, if the pain gets to be too much, the patient may have to come back to the hospital, but we're just maybe tweaking the pain medicines so that we can have better outcomes, but they're not necessarily coming back for us to do a full treatment plan. Any questions, comments? I told y'all it was a heavy topic. So, hospice is not focused on curing the patient. It's not. No intervention is designed to prolong the life. Well, we want to make the patient comfortable. We want to make the family comfortable. It's not a replacement for the nursing home. That's not what we do. We don't, we don't want them going to nursing home. We want to keep them at home. We're going to put them on hospice. That's not how hospice works. 24/7 care at the bedside by the family member. You get 24/7 care at the hospital by the medical team, but you know, people are not gonna care for grandma, grandpa, or mom or dad. You will get the same care. We just can't cure you. It's been documented. It's been researched. It has been appropriately charted in the chart by the different specialists and all involved. Everybody comes to a consensus, and this is where we are. Very difficult conversation to have. Very difficult conversation to have to pull the family together and kind of get everybody on the same page with what the team can and can no longer do for the patient. It's not an easy conversation, but it's one that happens on a regular basis.
I just wanted to know if there's a possibility that a person could be on hospice and while waiting on transplant, like, because I've heard of, a friend of mine told me that dad was going to liver transplant and they put him on hospice, but he didn't make it, but that was her word, that he was waiting on a transplant, so I didn't know if that was a reason that they could put you on hospice as well.
That's not typically what's done. So sounds like he needed that liver transplant to sustain life. So that's a cure to cure his liver disease. And everybody there are very strict rules with the transplants. So although you may need a transplant, but if you're still doing the things that you may have done to get to that point, then you may not be eligible for that transplant. So in the case of liver disease and liver transplant, if the patient still has a history of drinking and things of that, then no, they're not going to put you on that transplant waiting list. Smoking and all of that, no, they're not going to put you on that waiting list. So not sure what that case was. And sometimes it's a lot of he say, she say, and so it's very, at this point of the patient's medical treatment, I guess, all involved parties need to be at the table. That way everybody hears everything and the family can have a better discussion about what everybody heard and what we should do for our family. Everybody's gonna hear something different. Everybody's gonna hear what they want to hear, and then they're gonna argue about what they didn't want, what they heard that they didn't like. So it's best that when they have these conversations, they have everybody at the table that could have an influence in that patient's care. Palliative care. Palliative care is appropriate at any stage of a serious illness. At any stage, it's beneficial when provided along with treatments for curative or life-prolonging intent. So, what does that mean? What's an example? So, patient has a stage 4, perhaps, cancer, and we've used all the treatments that we could use, and we still need to give the patient radiation, maybe to shrink the tumor, to maybe help decrease the pain. Maybe when I say stage 4, I mean stage 4 with metastasis everywhere. So they're not treatable. But at the same time, we may give them radiation to help with the pain. So we're not curing, we're just making it a little better for the patient. It's provided over time to patients based on their needs, and it does not, and not their prognosis, just based on the need. Every now and again, a patient may require dialysis. They may not be a dialysis patient, but they may be so fluid overloaded that they need to have the dialysis palliatively, but it's not curing the fact that they actually need a new kidney or so on and so forth. It's offered in all settings. So you can get palliation you don't have to be on hospice to get palliative care. And it's offered in all settings. Inpatient, inpatient, outpatient, doctor's office, home health services, all of that, in home health services. What is home health services?
Essentially, you have a nurse come in
Physical therapy.
and manage the patient within the home.
Okay. So, who told y'all that before you got to this class? Or did you just have that experience?
I had that experience.
You had that experience? Because I find when they come to this one of the exercises, when you come to my site, that we have to go over home health services and what's the home health team, what's a SNF, what's a this, what's a that, before we can even get started on with the rotation. So that's good, that is right. Home health services is, everybody coming to the home and providing services to the patient. Nursing, sir, maybe the nurse may go there and do diabetic teaching. Maybe the the physical therapist may go and do wound care. Again, teaching them how to, occupational therapists may come in and teach them how to, now post-stroke, how to maneuver in their kitchen with a wheelchair. So those are things that home health services do provide. It's focused on what is most important to the patient, family, and caregivers, assessing their goals and purposes, and determine how best to achieve them. So what's most important? Want to keep the patient comfortable? So we focus on that. Again, interdisciplinary to attend to the holistic care of that patient. Palliative care aims to control pain control. Symptom management with morphine, midazolam, Haldol. Focuses on the quality of life versus curing the disease. All hospice care is palliative, but not all palliative care is hospice. Palliative care during hospice. Again, pain during terminal illness, physical, emotional, or spiritual in nature and origin. In hospice, palliative care aims to manage those physical symptoms, shortness of breath, pain, nausea, constipation. We may be given a lot of drugs that could be causing them to be constipated. So, we manage that. Side effects of medications, we manage that. In hospice care, a lot of those side effects that we're so afraid of in patients that we're actually working towards a cure, in hospice care, some of those side effects, we actually need them from the drugs. And so we use them a little differently, and we'll talk about that later. Hospice-based palliative care addresses issues of anxiety, insomnia, depression. End of life can cause quite a bit of anxiety, quite a bit of sleepless nights, and it can cause some depression.
Is there a team for the caregiver like that?
So the hospice team will be caring for the caregiver and offering psychosocial services as well. Yep. So they would have to, if they are experiencing anxiety or depression, the things that require actual treatment, then they would have to see their caregiver.
Okay.
But talking it out, counseling services, it could be under the hospice care team for the caregiver as well. That's a good question. Fear of the unknown. If you go back to 422, when we talked about empathy, as healthcare providers, this is where we really step in, and it's somebody's family member, it's somebody's, in that, some like, what that may look like. Some hospices offer other therapies. I did a pain management traineeship some years ago, early 2000s or so, in Connecticut, and I did it at a hospice house. And all the patients, I finished school, did a residency, and who knew that this existed? But they have, matter of fact, we have a hospice house right here in the medical center, right down the street from, you probably pass it and you don't even know it's there. Beautiful building. But I did a traineeship there, and some of the things that they did for treatment of the patients, treatment, not a good word, but therapy for the patients. They did art therapy. That's when I first learned about how art therapy, pet therapy, music therapy, all of that is other distracting ways, if you will, to soothe the patient and distract or maybe relieve some of this anxiety, maybe, from what they're actually going through. So I talked a lot about hospice at home with hospice, and you have a 24-hour family member or family members that are there with you, but you also have hospice facilities that some families do opt to send their patients to, their family member to the hospice facility. And they can go there and they can stay there for so long. Medicare, Medicaid, and most HMOs do pay for that. And they can go to the hospice facility. Some nursing homes, they have where they may have a hospice wing, if you will. And so if the patient was a nursing home patient and they go into the hospital for whatever reason and they come out and they're on hospice, they may be able to, with the family's consent, they may be able to go back to that facility, but they'll then transition into the hospice area. And they'll have but they still need the family support in those facilities. They won't have what people really are sensitive about is that if they know that the death is pending, they don't really want some families. They may not want the patient to be alone, so they opt to, even if they're in the hospice facility, they opt to stay there with them. And some of the places do allow that for you to be there with your loved one. That does happen. Okay, guys. I know it's a heavy topic. Everybody's just kind of, any questions, any comments? This is ACPE. This is a tier 2, and we got to give it to our pharmacy students now. We weren't giving it before, and I was the lucky one to have to give the topic, but it makes me sad when everybody's just looking back so sad back at me like this. But it is a conversation. It does happen. Those of you that are going into clinical pharmacy, you may see more of this. Those of you that are going into those of you that are going into the retail setting, you may not see it as much because you're probably dealing with the family member and whatnot. Those of you that may go into compounding pharmacy, you may see this because what we end up doing, because patients maybe they can't swallow, maybe they don't have IV access. So compounding pharmacists are very, very useful in this setting because they're able to compound the drug into suppositories and things of that, so we can still get the patient get their needs met, but we may have to do it in a non-traditional way because we're trying to get symptom management and relief.
What does it mean to be our hospice patient but non-resuscitation, whatever that is?
Huh?
What does it mean to be our hospice patient but with non-resuscitation and all? What does that mean?
With
Resuscitation.
Oh, okay. So you can't. Oh, okay. Good question. So if you're on hospice, you can't have them both. So hospice is you're signing off saying that we understand that our family member is there's nothing medical we can do. It may be a divine intervention, but we can't say we want all the services of hospice, all of the services that hospice order, and then we also say that we want them to be resuscitated. Because if you keep them on being resuscitated, if they still have if they have a DNR, if they don't have a DNR in place, that means every time anything happens, they get a little short of breath, you can bring them to the hospital, we can start a code, we can do chest compressions. If they're frail and already in a very weakened state, sometimes we do more damage than we do help. So the family has to really wrap their heads around that. If the patient gets to a certain point, we okay with opening up the box and doing what has been instructed, making the phone calls to the hospice team that this is what's happening and following whatever they tell you to do. But we can't have them both. It's confusing. And it can also open up for liability.
So if they're dying, you just let them die.
How's the meaning? Yes, nothing you can do.
And they also say you're not gonna call 911.
That's the same thing. We don't call 911 when we let things happen. We don't speed it up. We don't do a little extra. We follow. They'll give you very direct instructions on what to do and when. It's great when the patient is able to communicate a little bit with you, because then you can feed off of that. But when the patient is not able to communicate, it does make it difficult, and that's when you want to be there. That's when you want to be there. So, personal story. My dad. So we were. We had to talk. Everybody was there. And that was wild. But we had to come to understanding. And so they told us there's nothing else we can do for Mr. Charles. And so they decided that my dad would be, his death was more imminent. It was coming within days. So we decided to leave him there at the hospital where he was, and we did. But me, daughter, I was there every day, all day, right there at the bedside. So when nurse came in with all her little morphines and stuff, I could see that my dad was resting peacefully. He was not uncomfortable, and I was there to see that. So I said no. He couldn't communicate with us, but I knew he wasn't in pain. When he got to be in pain, he would have little grimaces in his face. He could hear me, Dad, you're in pain? And I could see movement. And then, okay. But I was there to, as a pharmacist, I was very concerned about that part of the hospice, because I didn't want, what does morphine do? So I didn't want it to be where it is, we're facilitating. We knew what was going to happen. We just have to but as long as he was comfortable in that bed, as long as I could see that he was comfortable, I was okay. So, I wasn't okay, but I was okay with them not giving them all the extra drugs. And just as they predicted, he passed peacefully right there within the days that they told us. And so we had to start the next process.
But imagine you not being there, like you have a clinical expertise. Imagine people that don't have that.
Imagine. So, imagine. So when we're at that, I'm not saying anybody is going to do anything wrong, but they have orders, and their orders may say 1 milligram morphine. And when you're at hospice, when you're in the hospital, you get these orders. the typical, you know what they are, hospice orders, and morphine, Haldol, Ativan, and they just come through your computer and you kind of know what's happening. But the order says Q1 hour, PRN.
Oh, wow.
If the patient not talking, if the patient not communicating, nurse is doing her nurse due diligence. She going in, she checking on the patient, and she doing a check off list. Not saying she doing anything wrong, but that order, I've seen them 23 years, that order says Q1 hour PRN. So every hour I'm going in, okay. She go back, you know, whether, I mean, how are you able to assess the patient not talking to you?
I don't know. It's only vitamin.
What, now do you see why it's so important that the family is there to be the voice? Even when in among your own family, there has to be someone who has enough wherewithal to take in what the hospice team is telling them to be able to execute these things for that patient. Doesn't mean anybody's doing anything wrong, but we kind of want to be a part of that. Any other questions or comments?
Have you seen any backlash? Just what you just spoke of, how the nurses follow the orders, they come in every hour, patient not speaking to them, they can't really assess the patient. Have you seen any backlash from that?
From the nurse or?
Yeah, like, no, from the family, like, you know, as far as, like, them getting in trouble, basically. Cause you know how you're just supposed to, like, assess the patient, talk to the patient, see how they're doing. What if the family member wasn't there, like you were there for your dad? Have you seen?
Well, so if the family wasn't there, then the hospital, the nursing team, they would just exercise the doctor's orders, whatever they are. So she had an order, and they would just follow through with that. But what I'm trying to say is that how you able to follow through with orders with a patient that's not, so it's gonna have to be some clinical judgment, and it's not always pharmacists that have to use clinical judgment. It'll have to be some clinical judgment on that nurse to try to get to the bottom of it. Do I really need to give this right now? In your leisure, there's a Netflix special called The Good Nurse.
Yeah.
Have y'all seen that? Anybody? In your leisure, check it out.
Okay.
Because The Good Nurse wasn't such a good nurse. Okay? And how? You don't have any what? You don't have any leisure? You guys are pretty great. Well, the good nurse would do some things that were not so good, and he was not far from here, Texas, doing things to the patients, and he would, just a summary, he would, didn't matter. Patient would come in with something simple, my finger, then they died. And they like, what? You know, so something would, it wasn't connecting, but nobody could figure out how is it that every time people had this nurse, the patient would die, and they didn't even come in with those type of illnesses. So he, and every time they got close to trying to figure out that, what did you do with something, he would leave and go to another facility. And he would go to the next facility, same thing would happen. By the time they started catching on that, you know, something ain't right, every time they come to you, when I had the patient, they were fine, and then they come to you. Long story short, he was adding insulin to their IV, their normal saline bags. He was doing all kind of things, and basically he, it's like hundreds of people that, true story, hundreds of people that he killed.
He or she.
You have to just watch to find out.
Huh?
She said why, I said you have to watch to find out, right?
Yeah, so in your leisure, It's called The Good Nurse. They have a documentary on it, and they also made a movie out of it. You can check it out. But and when family members were starting to like question, like when mom went in, you know, something with the nurse, nobody would even believe it because they're like, he was the good nurse. Like he had kids at home, he had a wife, he was living the life, soccer dad and all kind of stuff, but for whatever reason, he felt like this was it was okay for him to do these things.
Yeah, it's like purpose.
Huh?
Just like purpose.
Oh yeah. Yeah. So it took a lot of it's a very, you know, get a chance. I know y'all busy, but check it out. It's a doc like a 2-hour documentary, and then also it's a movie. You can do either one. I did the documentary, and I'm into all that crime stuff, so I did that one. But they actually have a movie about it where you know they kind of play it all out and stuff. So
Charles, maybe an extra credit if you watch it.
Nice try.
That's an incentive.
you get extra credit. Is it? We got this hot in here, y'all.
Yeah, that's what we do. Walk outside the cold.
So even though we're at end of life and there's not a cure for the disease state, patient is not going to get better, it doesn't mean we have to go to hospice. You can still just let the patient, and this happens all the time, the family just, you know, they decide no hospice and we don't believe what you're saying and everything is going to be fine. It's not mandatory, no pressure. But patients that do elect to do so, they do have access to all the services that are provided under hospice care. Hospice and long-term care. Long-term care is a fancy word for nursing home. And what do? We look at medications. We look at them a little different because the medications that we, like I said before, we may use them for one thing, we may be using them differently in a hospice setting. Old meds, new uses. End of life administration considerations. Remember we talked about some medications, maybe the patient not able to swallow. So now we gotta kind of think about other ways or other routes of administration we can give the patient. Pain and symptom management. Talking to the family, talking to the resident. Here, the Beers list has no role. Because remember, some of the side effects that we get from some of the drugs we use in hospice, we actually need those side effects. Remember, we talk about anxiety, we talk about insomnia, we talk about depression. Maybe some of the drugs that we use can cause sedation, and the patient is dealing with insomnia, so it's okay. It's okay for us to use. The Beers list does not apply to hospice patients or palliative patients. That's one of the rules for the Beers list. In hospice care, a lot of rules that we learn, a lot of guidelines, a lot of those things kind of go out the window because we're just trying to make the patient comfortable and the family comfortable. So patients, the absorption, end of life, pharmacokinetic, pharmacodynamic changes, absorption, they have changes in absorption. Because of increased age, patient may have varying plasma protein levels. What protein level do we most worry about?
Potassium.
Is
Oh,
potassium
wait,
a
did you say protein? I'm sorry.
Amino acid, no?
Huh?
No, it's not. Protein. Your
Albumin. I knew you knew it. Yeah, I could just tell the way your eyes perked up. Albumin. So what drugs are highly Did y'all do that already? Y'all done with kinetics? But the kinetics not done with y'all, your pharmacists. So that's always gonna be a part of what you do. You're gonna try to figure out, and your kinetics was one course, but it's gonna carry you through your profession. So as patients, or they have a decrease in body weight, increase in age, decrease in albumin, so drugs that are highly plasma protein bound may have certain toxicities that we have to be aware about. We're not trying to hurt the patient, we're just trying to make sure that they're comfortable and their family is as comfortable as possible. Metabolism phase, you have a decrease in blood flow, so again, decrease in the rate of drugs being broken down, and that can also lead to increase in toxicities. It's safe to assume that if it's renally eliminated, get rid of it if you can, because of all the renal function may decrease at this point. Hospice care services. Patient's home. Some people prefer to have these talks. There's another book, I'll post it in your chat, in your thing, if y'all want to use it as a resource with your families. I think it's called Death Over Dinner. And this is how you can, it's a casual book where you can talk with family about, what do you want? What do you want? We don't have these conversations. And then when we get there, it's a very difficult time for everybody. And then being that we don't typically have the conversations beforehand, it's even more difficult when those times arise. Hospice is available to any age, religion, race, or illness. You don't have to be with a certain illness, race, age, none of that. All of that, hospice is hospice. You have an expectancy of life of 6 months or less, and that means for you possible hospice care. It's covered under, as I said before, covered under Medicare, Medicaid, most private insurances. Any person who has a life-threatening or terminal illness with a prognosis of 6 months or less. You probably see that again. We talked about that 6 months or less throughout the whole presentation. But can one stay on hospice longer than that?
Yes.
Can one be discharged from hospice?
Yes.
Yeah, you can. You can. People get discharged from hospice. They do. They get discharged from hospice. It's not always the end. It just really depends on the patient. Every patient is different. We're all different. Everybody in here is different. It's for patients with cancer and non-cancer. Just because you have cancer doesn't mean you gotta go on hospice, or just because you don't have cancer doesn't mean that this is not an option. And even though the family member is there physically with the patient 24/7, the hospice care team is on call with the family. So they have numbers they can call the hospice care team at any time during that process. Levels of hospice care: routine, general inpatient care, inpatient respite care, we talked about respite care, continuous care. And typically, continuous care is kind of like where my dad was. We were in the ICU, and the discussions were made, and the decisions were made, the timeline was given, and so the team opted to, they didn't think that it would be long, and so he was allowed to stay where he was in the inpatient ICU setting, continuous care, but notice it says brief period. They knew he was sick enough that, he might not have made it to us trying to plan and pick a hospice and pick a family member and pick all of that, he might not have made it. And in this case, it was 72 hours or so, and that's where we were. Routine care is where you have the hospice team. Basically, the patient is home with hospice, and they have routine care. The physician, the nurses, and things. They don't come every day, but they have a schedule when they do come. Again, the family is there all the time, and they're just available by phone call, on call. General inpatient is your hospice facilities, or maybe a wing on the nursing at the nursing home. There may be a wing for just hospice patients, and then you have the inpatient respite care, where the patient can go there and give the caregiver some relief or some normalcy for a few days of whatever they want to do. Hospice should be considered when there's a significant decline in physical or cognitive status despite medical treatment, increase in pain, substantial weight loss, extreme fatigue, shortness of breath, or weakness. These are real basic general. So don't take this and say, oh, so-and-so has all this pain, they got to go on hospice. No, they have to have that diagnosis that whatever's causing the pain cannot be cured. Whatever's causing the shortness of breath cannot be cured. That's where the substantial weight loss, you see that a lot in our end-stage Alzheimer's patients because of all the lack of the chewing, the swallowing, and all of that. So you see that in those patients. So it's very patient-specific. It doesn't mean just because I, hit my toe and I got a lot of pain that you need hospice. The goal is to live more comfortably in whatever time you have remaining. Forego frequent physically treatments that you keep going getting these treatments and not getting better. Case in point, I had a dear friend of mine, a family member, had brain cancer that metastasized, and the treatment plan, the guidelines, they treated, they did everything they could do, and patient ended up at MD Anderson, great, but what does MD Anderson do?
Cancer.
Cancer. And they are the greatest, the best of the best. And so they're gonna try sometimes, remember we talked about, maybe we didn't get there yet, but sometimes we may do unorthodox treatments to try to get. We may use chemo that's FDA approved for this indication. They may use it for another indication, trying to get the results we want, a cure. So in this case, brain cancer, metastasized, still trying to keep the patient. So they tried a new agent that hadn't quite came to the market. It was under research, do a lot of research over there. And this thing was so potent that literally parts of the gums of the patient came out. That drug wasn't ready to get to application for FDA, but they tried it, because remember, before we get to hospice, we trying everything medically that we can. And sometimes when we get to that point, especially when we're in these very specialized settings, we will use drugs in different ways, trying to get the cure we want. Adults, children, adolescents, anybody is eligible for hospice care. Common diagnoses are listed there. Old medications, new uses. So maybe the shortness of breath is maybe it's so painful at this stage that we have to use a little bit of morphine to relieve some of that chest pain. Benzodiazepines, maybe the patient is 85 years old and we don't like these drugs in that population, but the shortness of breath is so painful that we have to use a benzo. NSAIDs, Bisphosphonates, calcitonin, bone pain, cholestyramine for itch, dexamethasone for anorexia, old drugs, same old drugs, but now we're using them in a hospice setting for different reasons. Haldol, olanzapine for nausea, hiccups, Vaseline, simple Vaseline over the counter for bowel impaction. Anybody know what a bowel impaction is?
They're unable to
Has to.
go.
You gotta go in there and get it out. You gotta go in there and get it out. Sometimes they do the soap suds enema, to try to, they're so impacted. We see this a lot in our geriatric patients. They're bloated, they're nauseated, and, they're just constipated. And so, we may have to try, to disimpact them. And Vaseline is one of the things, and soap suds, soap and water, to kind of loosen up the area down there so that we can get it out to give the patient some relief. Atropine eye drops, orally. What are the side effects of, atropine? Anticholinergic. So at end of life, and this is very painful to hear, the patient, all these, the saliva and things that we're so used to just swallowing, and we don't even know that we're doing it. Well, in the life, they might not be able to swallow. And so you have one trying to breathe, you have the saliva and the liquids in the mouth that can make this gurgling sound. You may hear the death rattle. And that, you may hear that term, the death rattle. That's not a fun thing to hear. So we may drop a little atropine there to dry up some of the secretions. Or we may use a scopolamine patch. What are side effects of scopolamine? Dry. Drying. So we may put a little scopolamine patch there on our hospice patient so that we can get some of that liquid, and so we don't hear the death rattle, the difficulty breathing, and then all mixed up with this saliva and everything. So again, old medicines, new uses. We have a topical H-bomb. This is where our compounding pharmacists come in, and they can make this ABH gel, Ativan, Benadryl, Haldol. This is common in our hospice medication pack or comfort pack. Itching, agitation, anxiety, all wrapped in one. We talked about routes of administration, considerations. Long-acting products, do you think this is a place for long-acting products?
No.
No. We need a fentanyl patch?
No.
Maybe. Maybe not. If it's a few days, then probably not. But if we don't know within that 6 months, maybe. Assess whether the dosage form can be continued. Can we go a different route? Do we need to go a different route? Again, hospice providers, they do try different routes and different practices that we didn't necessarily study, but there's a whole area, pain management for pharmacists, whole area of hospice care that pharmacists can get into. If this topic is of interest, you can definitely do a little bit more research on that. It'll be under pain management, but hospice kind of falls under that. Any questions, comments, or anything we can talk about? can be, where are we on that team? How do we make an impact in the life? Pharmacists.
Appropriate use of medication, maybe, looking out for toxicity, knowing the pharmacokinetics and how it could potentially affect the patient.
Knowing your patient, being familiar with your patient. So what are your take homes about hospice and palliative care? What are your take homes today? That you were not aware of prior to our discussion?
Which disease states you would recommend or consider hospice care?
Just end stage though. Because we get diagnosed with CHF, COPD, all of those things every day. People get those diagnoses, but the end stage, yes. What'd you say?
I said I didn't know, pharmacists had a role in, hospice. So,
Can be a role of home health services, can be a role of compounding services, clinical pharmacy. Yes. Under clinical pharmacy, it'll be more pain management, but there's a role.
And even in retail, right, being able, as a retail pharmacist, being able to recognize some of those orders and knowing maybe why the dosages are so high.
So in the retail setting, that's a good point. But how often you think, if the hospice team is providing the drugs, you think the patient is going to the family, is going to the pharmacy?
So I have seen that during my rotation where,
What pharmacy, was it outpatient pharmacy?
it's Kroger,
It was Kroger?
where they were receiving palliative care.
So was it Kroger directly from the patient, or was it
The family member.
the family member? Okay, okay.
family members.
Close by, sometimes maybe the location might vary, just like closer to one of the, homes or the palliative care homes or hospice homes, you might deal with it more. Or if it's in the, hospital, I mean, you know how they have the setting in the outpatient setting inside of the hospital, you might, I don't know.
Could, before, in your case, it could be that, again, it was some symptoms that outside of what was in the box that we still needed to treat. Very well possible.
Yes, and again, I don't know, I did not know that apart from caregivers, there are other side again, you were calling, is that respite or whatever? I was thinking it's only caregivers that can be taken care of, and they don't need any other side people coming in again. But up to now is when you are saying that there are other sets of people that you call respite. They come to relieve the caregiver.
Remember, they can't ever be left alone. And end-stage Alzheimer's disease, you cannot ever be alone. You don't know what's going to happen to the patient, and if that patient is still up and mobile, able to, somebody has to be there with them to facilitate their actions.
Yeah, but the caregiver, will it be only one person?
It depends on what the family dynamics are. It could be one person, and that becomes very hard. If you know the Alzheimer's Association, they have this big thing every November. Alzheimer's month is November. They have this big thing, caregiver awareness. In my sorority, we did a whole 4-year campaign on caregiving. Some of that caregiving is that now it's coming full circle where people are actually shining light. Caregiving is not easy. Because you're the caregiver, you can be the caregiver, but you also can be a full-time student. You could be mom, you could be dad, you could be grandkid, you could be a college student. caregiving for, even for your children can be a lot. And then you're caregiving for one that can't do for themselves, a sick person, that you have to manage doctor's appointments, hospice appointments, facilitate PT, OT coming in and out, medications. Caregiving is now, caregiving awareness is now having a spotlight on it. They need help. And what can we do for the caregiver? Now, if the patient has tons of family, it's great, because then everybody can take turns. And even still with that, the family gets burned out. Because now, family dynamics, ideally we want everybody to play nice and do their part, but it doesn't always work out like that. And typically 1 or 2 people, it kind of falls on them. And that's when it's like, okay, they need help too. And it's okay. We'll get them some help. We'll move the patient, give them a few days or we'll hire some people to come in and just sit because really a lot of times you just need a sitter there, or maybe respite is having somebody do some shopping for you, the grocery shopping, or coming in and helping with some meals and things of that. Giving the caregiver some support.
So people pay out of pocket or they use insurance for all this?
They can use Medicare, Medicaid, some HMOs and things, and sometimes they may have an out-of-pocket expense. Good question. Hospice services may be on the insurance, it may be one of the benefits. So then whatever those benefits are under the insurance, then you get all of that, once you sign on to the hospice services. Anything extra that's not provided, then it may be out of pocket.
I have a question. I'm going back to the old medication and new uses. And for the Vaseline, how exactly does that work with other bowel impaction?
So when they're impacted, they go in through the rectum and they use the Vaseline to just loosen the area. That's why I said in my practice they would use the soap suds enema. They would use the enema there and it would kind of loosen up because the bowels is there and it's just kind of stuck. So we go in with the Vaseline 3Z and just and once we break that mold, then whatever all is there will then start to come out. Typically, they probably try to give them something, at least what we used to do when I worked on the ACE unit, we'll try to give them something orally, while at the same time we're doing something from below. And once we, disimpact, if you will, then everything should start to come. It's not a clean process.
Right? Stuff in Vaseline.
Well, you're not stuffing Vaseline, you're just using it to help break that it's hard, it's solid, and you're just kind of using it to just kind of break the barrier, if you will, and then
I said, okay, I'm gonna do this. Put oil down in for you guys. That helped me.
it's not a fun process. It's typically nurses do it, but they get those orders, disimpact patient. I've done most of my career, it happens a lot in our older adults. They get impacted. They're not moving as much, they're not as mobile, and so they're still eating and they're taking all these medicines that can be constipating. So we run into problems sometimes with them. They're not taking enough fluids, enough water, and all of that. Not because they don't want to do it, they just, you're older and you don't really require it or want it as often. So these things happen. Any other questions, comments? No? Yes?
So I'm just wondering how you're going to phrase your questions on the exam. Because it seems
They'll be very general. There'll be more concepts. did we use? No, I'm not gonna do that. But you need to know that, we may use same old drugs and we may use them in a different way. You need to be familiar with that in general. But am I gonna highlight each one? Probably not. Now, if I talked about it in class, if I took time out and went through the whole kinetics of it in class, then I may pick that drug and ask a question about it.
Dr. Charles, geriatric syndromes are included in the exam.
Huh?
Will you test us on geriatric syndromes?
Say it again.
Will you test us on geriatric syndromes?
Uh-huh. I'm supposed to come back next week, right?
Yeah.
So we'll do a nice little thing on the beers. We'll go back. Y'all forgot all the beers already? Did y'all forget that already? Didn't y'all have it last semester? Huh? That wasn't y'all group? I don't come to 504? I do come to 504. When y'all have 504?
MTN.
We didn't talk about the beers list? No?
You know something's going on.
So that's what we're gonna do next time. It's all about the beers. The beers list. And any other questions, comments about hospice, palliative care, caregiving, pharmacists?
Dr. Charles, a quick question. So would you recommend home hospice over taking the, if it's a relative, to taking the patient to a facility?
You know, I don't know. I really don't know. It's a great question. You really have to weigh out the options and what, each case and each situation is totally different. You know, it's really gonna be what the family wants, what the patient wants. Some patients, when they have that discussion with the team in an inpatient setting, they say, I wanna die at home. And then some